Let's talk about COPD. So, COPD is chronic obstructive pulmonary disorder. There are two main disorders that are classified as COPD. So, COPD is an umbrella term. So, COPD includes emphysema and chronic bronchitis. So, let's talk about some of the similarities and differences between these two respiratory diseases. Both of these are chronic respiratory disorders. Obviously, they're both classified as obstructive disorders rather than restrictive disorders. But there are some main differences. I want to say, though, that very, very rarely does a patient have pure emphysema or pure chronic bronchitis. The vast majority of our COPDers have a mix of both. But for test-taking purposes, you need to know how to differentiate. So first, over here with emphysema, we have our pink puffers. Why do they call emphysema patients pink puffers? So first, let's talk about our risk factors, which are smoking, number one, and number two, something called alpha-1 antitrypsin deficiency. Basically, people with this deficiency lack an enzyme that helps protect them from losing elastin in their alveoli. So the smoking or the deficiency of alpha-1 antitrypsin leads to chronic changes within the alveoli, which is the very smallest part of the respiratory system. This is where gas exchange takes place. The elastin in the alveoli is destroyed. They lose their elasticity. And so the alveoli then tend to become what we call hyperinflated, and gas exchange is prevented. All right. So those chronic changes lead to some very key signs and symptoms. What does a patient with newly undiagnosed emphysema present to the clinic with? They show up to the clinic and they say, I'm just feeling really short of breath lately, way more short of breath than normal. So progressive dyspnea. Okay. So these people, in summary, they have progressive destructive changes to the elastin in their alveoli, leading to a loss of elasticity or a loss of bounce back of the alveoli, which is the gas exchange unit. So this leads to a hyperinflation of the alveoli. In other words, the alveoli have air trapping going on. So these patients are able to breathe in, but they're not able to breathe out because those alveoli are not elastic and they don't bounce back anymore. So the patient comes in saying that they're just very, very short of breath, and they report progressive worsening dyspnea. Okay. So what do these patients look like? Something called an increased AP to lateral diameter. So anterior posterior is our AP. So our front to back diameter is typically smaller than our lateral diameter, which is side to side, but not in a patient with emphysema because of the hyperinflation of the alveoli. This is something called barrel chest. So barrel chest, or a 1-to-1 AP to lateral diameter, or an increased AP to lateral diameter, those are all the same thing. Progressive dyspnea. You will see patients performing what's called pursed lip breathing to try to get the air out of their lungs, and they'll be sometimes in the tripod position when they're trying to get air out. So they're trying to get air out. All right, getting air in is not the problem. Getting it out is. So on the flip side, chronic bronchitis, what are our risk factors? Smoking, just pure smoking. So that smoking causes progressive severe irritation and inflammation within the bronchi. So the bronchi are what is damaged here. So that constant irritation of the bronchi overactivates the goblet cells within the bronchi. So those goblet cells are mucus producing cells. So they become overactive over time because of the chronic exposure to smoke and smoking, and they overproduce mucus. That leads to mucus plugging, which leads to the chronic hypoxemia that we see with chronic bronchitis. But the overproduction of sputum by the goblet cells produces that key characteristic manifestation, which is a productive cough. So with emphysema, our patient's going to come in reporting progressive dyspnea. With chronic bronchitis, they're going to come in reporting a new productive cough that they just can't get rid of. All right. So with chronic bronchitis, we often hear the term blue boaters. They are called blue boaters because they have a tendency to become more cyanotic because chronic bronchitis causes much more severe hypoxemia than does emphysema. Emphysema, remember, it's a condition that prevents the patient from getting the air out. With chronic bronchitis, there's mucus plugging, preventing them from getting air in. So the hypoxemia is worse, causing kind of a cyanotic color or a bluish color, making them a blue boater. With emphysema, they're called pink puffers. Okay, so why are they pink? Well, something called compensatory polycythemia happens where the body overproduces red blood cells to compensate for hypoxemia. And so that's what gives our emphysema patients the pinkish color. It is very difficult for patients with severe emphysema to eat. Sometimes they have to choose between eating or breathing. So they're going to be more thin and they're going to be pink because of the polycythemia. Over here, the polycythemia is happening in chronic bronchitis, but the hypoxemia is so much more severe that they're not going to turn pink. They're going to still have that bluish color, so that's why they're blue boaters. And they tend to be more overweight, whereas our emphysema patients tend to be more cachectic or very, very thin because it's eat or breathe much of the time. Also with chronic bronchitis, these patients are much more prone to cardiac complications associated with their respiratory disorder. Okay, so things like cor pulmonale, like right-sided heart failure, is much more of a risk with chronic bronchitis. So how do we diagnose? It's basically on physical examination. So our chronic bronchitis patient is going to have a cough that lasts for more than 3 months for 2 consecutive years. Okay, it's going to be a productive cough. And so we'll take sputum samples and that type of thing. But a cough that lasts for more than 3 months for 2 consecutive years is pretty much diagnostic of chronic bronchitis. With emphysema, again, we're going to go by our physical findings. History, is the patient a long-term smoker? The reports of progressive dyspnea. Also on chest x-ray, you're going to see hyperinflation of those lungs. And so that's pretty diagnostic of emphysema. So that pretty well wraps up emphysema versus chronic bronchitis. I hope that kind of gives you a little bit of a better understanding of how to differentiate these two disorders, because on your patho exams, on your med-surg exams, that's key, is to be able to differentiate. But do remember that in the real world, most of our patients are going to have a mix of both of these respiratory disorders. Okay, so hope that helps. Happy studying and go Vols.